I first want to thank Carol and Frank for the kind invitation and the great meeting that you put together. And then I also want to thank the Scientific Advisory Committee to ask me about something that I have no experience with, and that is designing clinical trials. However, I do have now some experience in learning how it may play out if you are in a clinical trial. So I have over the last now 12 years been involved as a site PI in a couple of clinical industry-sponsored clinical trials with very opposite outcomes, very successful and complete failure. And so funny, just mentioned a classical example, if you fail on primary endpoint, it is a disaster. So that is why I try to kind of outline a little bit my thoughts that I have on that. It's not a systematic presentation, it's just, but before I go to this disclosure, so related to this creatine topic, it is least that I was a consultant for Ceres and also for Ultragenics that work in this field. So what is our goal? Our goal is to bring an efficient treatment on the market. That is what we need to accomplish in a clinical trial, because that is why those trials are done. How can we get this done? We have to convince the regulator. So the regulator in Europe is the EMA, in the US it's the FDA, in Canada it's Health Canada. Health Canada is the easiest, but that's not really what would help. So, and yes, indeed, the regulators usually, they want to see clinical improvement. So now, what do we have to consider? And I will talk about both CTD and GAMT deficiency. So first, we have a small number of patients, so we won't get 100 in a group. And then very important, I think it is fair to say it is a non-progressive disease, even if the parents may not agree with me because they see how things get worse over time, perhaps. But this is because the kids get older, so it becomes more obvious. But in fact, it is not really a progressive disease. That means a treatment with a goal to slow progression wouldn't work. So, and then also sad to say that, but we have very strong evidence that there is an early brain impairment with those diseases that in many parts is irreversible. So even if we get the cure for a 20-year-old, we don't know what it will change, because there are functions in the brain that we get during differentiation of the brain, usually in the first 4 years of life, when things are built, so like speech, language, behavior. And so if that is finished, then when we later have an intervention that makes everything better, can we expect that someone learns speech? No, for sure not. That's what we can say for sure. How does it change the behavior? Hard to say. So that is something one has to keep in mind in clinical trials for CTD. And we don't have a reliable biomarker. We talked about this, and I will go into this, at least talking about the brain creatine a little bit more. But FDG PET was one, the near-infrared spectroscopy is another one. So we don't have a good biomarker that a regulator would accept as a primary endpoint. And I mentioned this already. So if we are successful, how do we expect to be the change on the behavior of a child? And that's perhaps a good thing. Right now, for those clinical trials, we still don't have a treatment for this condition. So if we compare this with GAMT deficiency, it's a little bit different. In terms of number of patients, yeah, even less than that. It's, again, not a progressive disease. Again, the same, early irreversible brain impairment, but the seizure disorder is reversible. That's a huge difference. And we do have a reliable biomarker, guanidinoacetate, and even creatine can be used as a reliable biomarker. So the uncertainty, that's perhaps not so relevant. But another huge difference is there is an effective treatment. And this has to be kept in mind when we design a clinical trial. So now I want to talk about, why don't we see that? Okay, now we see it. The creatine as a biomarker, brain creatine. So what we have set up, it's the kids already 13 years ago, is we have a protocol that basically every child that gets a brain MRI gets also an MR spectroscopy, and the standard protocol is 2 locations in the basal ganglia and the periventricular basal ganglia and the periventricular white matter. And then those data are fed into a post-scan software called LC model. It goes on a server and it gets printed out and it gets saved. And then, so what you see on the right, this is what the scanner produces. It looks like a nice spectrum, but the LC model is a software, and it was shown earlier today, that is able to integrate certain metabolites. So the peaks that you get here in red are really the metabolites that you want to measure. So for example, this is creatine. And then with LC model, we have all those data, and we developed a tool that you now can plot those data against thousands of basically reference data. Because that's a problem when we have those new methods, we don't have a good reference range. It's age dependent and so on. So what you can do, and by the way, so you can see the internet link, everyone can do that. So you can enter this, and then you can enter your LC model data when you did MR spectroscopy, and can see where your measurement is plotting against. So for example, when we plot total NAA, and we want to see what is the normal range, that's the blue, that in red is plus minus 0.5 standard deviation. So the stability in the brain is usually pretty good, so we don't need to look for plus minus 2 standard deviations. I think plus minus 1 standard deviation is already defining the normal range. And it was also shown this morning that when you use, for example, 3 Tesla scanner, you can you can differentiate between total creatine, phosphocreatine, and creatine. And there you can, for example, see that phosphocreatine over time remains completely stable. So this is from 0 to 18 years. We don't have adult data because we are a children's hospital, so everything ends at 18. And then you see the creatine concentration goes up, and total creatine has this shape. So the other thing, if we want to compare between different centers, because everyone who has MR spectroscopy can run those sequences. Some have a 1.5 Tesla scanner, others have a 3 Tesla scanner, and unfortunately, quantitatively, there is a difference, not for all of the metabolites, but for total creatine. So if you measure with a 1.5 Tesla scanner, you get a little bit lower data than with a 3 Tesla scanner. But still, one can compare this if one does a clinical study, and different imaging units are running that. But in order to use this not only as a visual tool, but a quantitative tool, we set up another tool that is our normalization quantitative MRS tool. At the end of the day, what you do, you put in the number that you measured. Let's say creatine was 15 in the basal ganglia, and you have the age of the child, 2 years old, and then what you get is you get the percentile range and the standard deviation score. And if you do that, and you do this 2 years later and 4 years later, or whatsoever, you can see whether it gets better or not. So we have those tools, and now I just want to show you a couple of examples. That was, for example, a boy that I treated, a transporter patient, since he was below 2 years of age, initially with creatine, arginine, glycine. It looks like there is an improvement. Then later we added S-adenosylmethionine, but it was not really an improvement, and you can see how much lower it is compared to normal data. If you look at the standard deviation score, it dropped all the time. So there was not even an improvement here, although it appears that way, it is not. So the defect becomes more obvious over time. And so that is another patient that I follow for a couple of years, and you can, unfortunately, our unit, they changed from 1.5 to 3, and I'm not sitting there, so I cannot say, oh, you used the wrong scanner. I just get the results, and then I learn, they didn't do this on the same scanner than before. So anyway, but if you plot all of that together, you can see there's basically no change over the years with those precursor treatments. And it is low, let's say, below 5 in this range. So that's another patient. You don't see much of a creatine peak, and you can see how far it is below. By the way, you can also measure guanidino acetate, and I have no evidence that it is elevated in the brain. And now we talked this morning about the girls. We shouldn't forget the girls, right? So I have at least, I had two, but now I have still one. And she, so you can see her creatine levels in the basal ganglia in early time, they were better. I started treating her with creatine and the precursors, but there were, I'm pretty sure she didn't take anything. She had really a pleasant, a peculiar behavior, I would say. Very lovely, but she wouldn't do anything what someone asked her to do. But somehow, sometime, it changed. So now she is really, she eats out of my hands, you know, when I say, can you do that? Yeah, sure. So I guess she takes the medication, and it looks like it gets better, right? But why I'm showing you this is because we have to think about, is this a reliable parameter for a clinical trial? So that is why I'm showing you. And I want to show you something when we think about how important is it to improve creatine in the brain, and how far do we have to come in a clinical trial? How much do we know about that? So I show you as an example a different condition. It's a secondary creatine deficiency, and it is called gyrate atrophy or ornithine aminotransferase deficiency. So in this, if this enzyme doesn't work, you get a buildup of ornithine. And ornithine is a very potent inhibitor of the first enzyme in the creatine synthesis, agat. So those patients, they have a very low creatine in the brain, and they have other problems, but I also treat them with creatine, and we try to reduce ornithine with a diet. So these are levels of different patients, so 7 different patients and their brain creatine levels. We talk about this later, but you can see that the majority of them are clearly below normal. So they have indeed creatine deficiency in the brain, but when you compare this with the CTD patients, they were even lower, right? So the interesting part is, and this is, by the way, in the white matter, interesting part is those patients, they have normal speech, they have usually average intellectual capabilities, so they are not at all comparable with CTD. And still, they have significant brain creatine deficiency, there is no doubt. So, and then that is an example, that is a girl. So she started also very low, but over the course of 2 years, she normalized. So she came with, had a standard deviation score of -4, and now she is at 2. And even the white matter, it has normalized. Now I could say, oh, wow, that is because I gave her creatine, but it is most likely not the creatine supplementation. The thing is, we were able to reduce her ornithine, so she has no inhibition anymore. That means if you can change the creatine synthesis in the brain, then you can get normalization. But creatine supplementation itself, it's questionable. Oh, sorry. Yeah, so Fanny asked me last week when we talked briefly about today, so what can we expect perhaps if we treat an adult? And that's what I wanted to show you. But this is as Rima this morning explained, EE. This is epileptic encephalopathy. That's a patient with GAMT deficiency. He was 26 years old when he was diagnosed and when I saw him the first. So he has a severe epileptic syndrome with absence seizures, and so he's wheelchair bound, he is nonverbal, he is in a foster home, but he is not he doesn't get schooling or anything. So, by the way, and but interestingly, normal brain. So when we did the MRI, no abnormalities in the imaging. And then 1 year later, after we started the treatment, so, I mean, he didn't learn speech, but he has comprehensive speech. He understands the concept of time. So he's now in a junior kindergarten group there. But that is because we were able to control the seizures. That is most likely not because we got more creatine in his brain, but we could control the seizures. So that's something that works for GAMT deficiency, but it would perhaps not be something for creatine transporter. So to summarize, what would I consider for those trials, or what do we have to think about? And part of it, Fanny mentioned already. So for CTD, which age group and which sex? So are we combining girls and boys? Perhaps, yeah, I'm not saying yes or no, I'm just saying that has to be considered. And age, will we have a group of pre-symptomatic or early symptomatic children versus older children? The older children, we would have different expectation compared to a younger child. Next is, I think it has to be placebo-controlled and randomized. We have small groups, and the effect size may not be very, very large, so that is why we have really to demonstrate that this is due to the treatment, and double-blind. I was thinking, so those studies where you compare the patient as his own control. So for example, an on-off trial. You put them on, you take them off, you put them on, you take them off. And you see what the difference is. You may not see a constant improvement in cognitive abilities, but you may see the signal goes on and off when you treat or when you not treat. So that's an idea. And then exactly the same what Fanny said. So we really need to learn, we need to know which endpoints do we want. So we have to be convinced that those endpoints will work. And secondary endpoints could, for example, be brain creatine, could be FDG PET, could be near-infrared spectroscopy, and, for example, behavioral changes. Not necessarily behavioral improvement, but behavioral changes. So for GAMT, age, again, pre-symptomatic, early symptomatic versus already older children. Again, it should be placebo-controlled, randomized, and double-blind. Here we can do a cohort study. So basically just taking GAMT patient and randomize them in treatment and placebo. But here we have to keep in mind, we will not have any patient who is not on treatment already. I will show you a little bit tomorrow in the newborn screening session about that. So, and we cannot stop the treatment because the seizures would reoccur. So we have to basically do the withdrawal of the prior treatment and no occurrence of new symptoms as the endpoint somehow. It's tricky, but I guess that's the only way we can do that. And we have some reliable biomarkers. And then secondary endpoints, EEG, brain creatine measurements, neurocognitive tests. And that's basically it. So thank you.